much. Very good morning. Thank you, and honorable chairperson and panelists. Today I'm going to present on the different facets of VT. Let's start with the history. 55 years old diabetic and normotensive female admitted to the hospital with a palpitation, dizziness, and shortness of breath for last 5 days. And patient was hemodynamically stable with a pulse 190 beat per minute and features showing the features of heart failure. This was the ECG done in the emergency department. It shows the garden variety of white complex regular tachycardia with the evidence of AV dissociation has been seen with a extreme left axis deviation. So this is a VT. From this ECG, we also denote that this is a LBB morphology in the V1. That means it arises from the right ventricle, and 2,3 AVF shows it comes from the inferior wall. So after giving the DC cardioversion 200 joule, it reverted back to the sinus rhythm. There's some RBB morphology and some gross T inversion can be seen in the all leads. We have already done the echocardiogram. It shows hugely dilated RV with the LVF 35 to 40% with the global hypokinesia. RV-P is hugely dilated, and TAPS is around 6 millimeter with a severe RV dysfunction, and there's a large thrombus hanging from the RV. So with that echo, retrogradely, we actually give a second look of the ECG. Here we can see there's some nodes just after the QRS complex, so that might be a epsilon wave with a QRS widening, localized QRS widening of the almost 150 milliseconds, and there is a prolonged S-wave upstroke, more than 55 milliseconds can be seen in the V1. So as we know, in the ARVD, there's some apoptosis and the fibrofatty replacement of the myocardium, especially the triangle of dysplasia, especially RVOT, infralateral wall of the tricuspid valve, and RV apex. The studies show VT is unlikely arise from the RV apex. That ECG also gives some clues of the VT exit points. If the lead 1 is positive, it means it exited from the RV basal region, and QRS is positive in the AVR, that means it is from the inferior RV exit. And if there is a Q wave in 2, 3, and AVF, that means it is inferior RV epicardial wall. So already we have done some investigation. There's some tropile leak can be seen. CAG shows mild coronary artery disease, and Holter shows 6,000 PVC per 24 hours. So there is no doubt about that this patient needs an ICD. This is a class 1 indication. Added with that, there should be a highest dose of titrated, tolerated beta blocker with anti-failure management, plus minus antiarrhythmic drugs such as amidone or sotalol with anticoagulation for the thrombus, with a restriction of the moderate to high intensity recreational activities. So now comes the versatile aspect of this VT of this patient. Some point of time, this patient also developed the RBB morphology VT. That means LV is also diseased, or there's a large distortion of the myocardium or the heart itself. Some point of time, this patient also develops some junctional bradycardia with a prolonged retrograde VA also can be seen. Ultimately, patient developed the ventricular flutter, and after 21 days later, patient actually expired. In discussion part, this is a hallmark pathological findings of progressive myocyte loss and fibrofatty tissue replacement seen in the ARVD. This is an autosomal dominant disease. Some autosomal recessive trait can be seen in the Nexus disease or Carvajal disease, mainly involve the RV with the epicardium to mid-myocardium. Epsilon wave is the hallmark of the feature of ARVC. This is denotes the delayed activation of the RV wall and the outflow tract, mainly affect the endocardial scarring, addition on the epicardial scarring also, but this is not exclusive to the ARVC. That can be also seen in the RV infarction or sarcoidosis. Fontaine lead can be helpful to accentuate the epsilon wave also. So I'm not going to conclude this session. I'm just leaving some question for the expert panelists. There are some 4 differential for this patient. Sarcoidosis, Chagas disease, amyloidosis, and myocarditis. So how we can actually differentiate VT from these groups of disease? and choice of anticoagulation, in-stage management for the ARVD, role of EPRFA, and role of family screening in these cases.
Any question from the audience regarding the presentation of